contemporary management of heart failure، ودي هتبقى المحاضرة التالية للجست الأول اللي هو بروفيسور توماس لوتشر. بروفيسور توماس لوتشر هو بروفيسور اوف كارديوفاسكولار ميديسن، وهو رئيس وحدة الكارديو ميتابوليك يونت في هارفيلد كينجز كوليدج. هو يعني دويتش شفايتس، يعني هو ألماني على سويسري، لكنه حاليا في انجلترا، وهو رئيس جمعية القلب الأوروبية. التوبيك اللي هيتكلم عنه النهارده هو البروجريس of cardiovascular medications from herbs up to the genetic scissors، وازاي من خلال الجينز ممكن يحصل يعني contemporary management لحاجات كتيرة من الجينيتك disorders. فهنبدأ بروفيسور توماس لوتشر.
Hello everybody, attending the 7th International Conference of the Egyptian Society of Metabolic Syndrome, and we are so glad this year with having many professors from all over the world, and we have today Professor Thomas Luescher, MD FRCP, Professor of Cardiology, King's College, and Director of Research, Education and Development, a consultant cardiologist in Royal Brompton and Hartfield Hospital, London, UK, and Center of Molecular Cardiology, University of Zurich, Switzerland. Professor Thomas Luescher actually has many contributions to the literature of cardiovascular disease. One of his very recent papers was about the evolution of cardiovascular pharmacotherapy from herbs to pills, antibodies, and nucleic acids, which is his talk today. We are so honored that we have Professor Thomas Luescher with us virtually today, but we hope that very few time we will have him on board physically in Egypt, in Ismailia, which I hope this will be very coming soon. Professor Luescher.
Well, thank you very much. It's a pleasure to talk to you about the herb to pills, to antibodies and nucleic acids. And I will dwell a little bit on history. And, first of all, the first herbs that we used specifically for heart disease have been developed by a lady called Mother Hutton, a herbalist. And William Withering, a famous physician at that time in 1784, saw that she gave this to people that had dropsy, and they started to pee, and they got rid of their edema. And so that's what he wrote then in a large book. He didn't publish papers, but rather a book where he meticulously described all the cases. But it took many years, actually 1930, where the complex steroid structure of digitalis was discovered. And today we know it is very useful drug symptomatically, not sure whether it reduces mortality. Then around the same time, in the 30s, then late 20s rather, this gentleman, Alexander Fleming, went to for holidays for 3 weeks and was a bit, not very careful with his probes, and left some mold juice just sitting around. And then when he came back from holidays, he discovered that some of his bacteria would not grow where there was mold. And then, of course, he discovered penicillin that in 1942 was also sequenced in terms of its structure that you see here. And then, of course, these three gentlemen got the Nobel Prize for the discovery and, of course, characterization of penicillin. This was a major breakthrough in history. But it went further. The Sandoz at the time, now Novartis, asked his employees to bring some probes from the ground from Norway, and one of them found this Tolibaclobium inflatum, a very complex structure that these molds produce. And then, of course, Hermann Stadlin and later also Jean-François Borel discovered its anti-inflammatory properties, and cyclosporin it revolutionized transplantation surgery, initially in kidney transplantation and later heart transplantation. Again, a major breakthrough in medicine. And then there was a employee of a pharmaceutical company in Osaka, Japan, called Akira Endo, and he suspected that fungi like molds and mushrooms would produce antibiotics that inhibited HMG coenzyme reductase. So he was inspired by Fleming's success and tested over 3,800 strains of fungi, and eventually discovered what we today call statins, copeptin and then lovastatin, and he would actually deserve the Nobel Prize. He probably saved more people than ever since Fleming's seminal discovery of penicillin with this new medication. And then, of course, with antibody-antigen interactions, we learned from nature that we can take advantage of the immune system and produce monoclonal antibodies like this one that was developed in rheumatology called infliximab, that then, of course, helped many patients with rheumatoid joint disease. And of course, this also was then later developed in cardiovascular medicine. And as you know well, there is an innate immunity is activated through the NLRP3 inflammasome that then leads to cytokines such as interleukin-1 beta. And there was an antibody called canakinumab that was tested in patients after acute coronary syndromes, and it led indeed to a reduction of cardiovascular events of around 18%. But when they actually did a sub-analysis, they found that those where interleukin-6 was markedly reduced by the antibody, not just interleukin-1 beta, they had the biggest benefit. And this now led to the development of interleukin-6 inhibition as a new therapeutic strategy with specific antibodies. First of all, in the rescue trial, a phase 2 trial, showing that this antibody interleukin-6 indeed massively reduced CRP in patients at high risk. And currently, there are several trials now testing this antibody in a large scale in phase 3 trials in patients with high risk and renal dysfunction. Another seminal discovery was mutations in the PCSK9 gene that indeed causes autosomal dominant hypercholesteremia. And this it was by Catherine Boileau's team in Paris. And eventually their discovery led to antibodies against PCSK9 that indeed now we are using based on the Fourier and the Odyssey trial in our patients that still have high cholesterol in spite of statins and ezetimibe. Furthermore, there are new proteins that may be interesting in cardiogenic shock. As you know, cardiogenic shock is a frontier in cardiovascular medicine with still a mortality of around 50%. In mice, after coronary ligation, as you can see here, there's a decrease in shortening fraction of the heart if you ligate the LAD. And if you add an antibody against this dipeptidyl peptidase 3, you can normalize hemodynamics completely. So this peptide inhibits a player in cardiogenic shock called dipeptidyl peptidase 3 that digests angiotensin, has negative inotropic effects. And the question was, of course, is this also important in humans? And we published this with Florian Wenzel in a European Heart Journal 1.5 years ago, showing that circulating DPP3 in patients with acute coronary syndromes is hugely associated with cardiogenic shock, and therefore maybe a new therapeutic target that we're now investigating was this antibody against DPP3 in patients with cardiogenic shock. Then, of course, we moved from antibodies to nucleic acids, and this is the Nobel Prize in Physiology and Medicine in 2006 by Andrew Fire and Craig Mello. They discovered in C. elegans, a little worm that lives only 2-3 weeks, the silencing inhibition of RNA, the sRNA principle. And this today now is really a new therapeutic strategy of revolution in pharmacotherapy using RNA interference primarily, but also antisense technology. while antisense technology on the left is a single strand that then enters the nucleus and then interferes with RNase H and digests messenger RNA that has been copied from our DNA to prevent protein formation. This is particularly suitable for gene therapy because it enters the nucleus. RNA interference is different. First of all, it's a double-stranded RNA, and then it enters not the nucleus, but remains in the cytoplasm, interfering with the RISC, the RNA-induced silencing complex, where it sticks around for several months and therefore allows for an inhibition of protein formation from the messenger RNA over several months to half a year. And this is how it works. It mainly is suitable currently to interfere with proteins produced by the liver. But this is because the liver has these acyl-glycoprotein receptors that are specifically expressed on the liver surface of hepatocytes. And if you have a tag attached to it, the GalNAc, the N-acetylglycosamine, that then interferes with this receptor, you can specifically target proteins produced by the liver and inhibit them completely for several months. The paradigmatic example is inclisiran that has been tested in patients with high cardiovascular risk with elevated LDL cholesterol. And here you see on the left, over a 1 year period, the decrease in PCSK9 in the range of 50-60%, and on the right, LDL cholesterol. So with 2 shots in a year, you can actually lower LDL cholesterol substantially on top of statins. But there is more to it. Another protein that's produced by the liver is angiotensinogen. And angiotensinogen, as you know well, is the first step in the renin-angiotensin system. So to block the protein formation in the liver would have severe consequences on the activity of the renin-angiotensin system. And here you see down below the percentage change from baseline in angiotensinogen levels, and you can see a dose-dependent reduction by silabesiran, this RNA interference, siRNA, and you can basically inhibit angiotensin formation of close to 100% over 24 weeks, so also around half a year's time. But of course you will ask if I'm just not interested in only in the angiotensinogen, I would like to see what blood pressure does. And here is the result at week 24 with this particular dose of 800 milligram. You can see a substantial reduction in both systolic and in red and diastolic and blue blood pressure. So this is a new treatment that may potentially improve the compliance with antihypertensive therapy, both in hypertension, but potentially also in heart failure. Another protein produced by the liver is lipoprotein a, which is a novel cardiovascular risk factor. In fact, it's not novel, but it has been tested in a Mendelian randomization study showing causality of lipoprotein a with cardiovascular outcome. And now with PCSK9 inhibitors, you can actually reduce it a little bit. You can see here in those with low lipoprotein a is not so much reduction, but in those with LDL lipoprotein a levels above 120 nanomoles per liter, there's about 15-20% reduction of lipoprotein a. So this is what we have today with an antibody. But if we are actually inhibiting the formation of the protein with an antisense oligonucleotide, you can see you can reduce lipoprotein a by 80% with the highest dose injected every week. But now there is also a small interfering RNA to reduce lipoprotein a in cardiovascular disease, and you can see on the left the change in lipoprotein concentrations dose-dependently, close to 100% reduction, and this is on the right is placebo adjusted, so even then it's really substantial reduction between 80 and close to 100%. So we're looking forward to have phase 3 trials showing us that this indeed also reduces events, but based on epidemiology and Mendelian randomization studies, we're pretty confident that this will really indeed reduce myocardial infarction and premature death. Then we move on to amyloid heart disease. And indeed, transthyretin protein is also produced by the liver, and then of course accumulates, as you know well, in the heart, in the valves, as you can see in this example, but also in the left ventricular myocardium and the right ventricular myocardium, leading to typical ECG changes because it reduces the electrical current as well and leads to low voltage in the peripheral ECG. And of course, you can reduce this also by an antibody. This is a phase 1 trial with an antibody N1006 for depletion of cardiac transthyretin amyloid. And you can see with the DPD scintigraphy that from baseline to 4 and 12 months, there's a huge reduction in a protein in the heart using an antibody. But again, maybe you want to actually prevent the formation of it. And here there have been several siRNAs, vutrisiran, presented by Mariana Fontana in London last August at the ESC Congress, and then published in the New England Journal of Medicine, showed that the time to first event in the overall population already started to diverge at month 6. And then at month 18 reached also mortality. So this is a very effective treatment of TTR amyloidosis. It does not cure it, as you can see, because there's still, of course, a decline in the event-free survival, but there is a marked reduction in the event rate. So in summary, we can say, while in the old days we had to take pills, for instance, high-potency statins 365 days a year, with antibodies we are getting down to 26 injections. With siRNAs, 2 injections a year, very similar to vaccination, and with gene editing, possibly once in a lifetime. So clearly adherence would markedly increase under these conditions, and target level compliance as well. And indeed, now we have something that may cure rather than treat patients. This is CRISPR-Cas9, the gene scissor that can specifically delete genes or exchange genes or change the nucleic acid sequence to inhibit the actual activity of the gene in terms of messenger RNA production to a vital protein. And this has been awarded the Nobel Prize to Emmanuel Charpentier and Jennifer Doudna some years ago, and really is another revolution in pharmacotherapy. First of all, this has been applied to embryons that you have lower right, that this is an embryo in red that has the mutation, and in blue it would be a wild type. And using CRISPR-Cas9, they could actually cure this embryo from hypertrophic cardiomyopathy by exchanging the gene into a wild type gene. But it goes further. Also, dilated cardiomyopathy is a huge problem and is genetically determined. This is precise genome editing of a pathogenic mutation in RBM20 to rescue dilated cardiomyopathy. And in panel C, you see the wild type on the left, and on the right, the mouse with the mutation of RBM20 that leads to a dilated cardiomyopathy, and in the middle, the rescue is through genomic editing of this gene. But this also may be relevant for our atherosclerosis, because there are sequence variation in PCSK9 that are associated with low LDL. It's a missense mutation, and it provides protection against coronary artery disease. And here is the evidence. You can see that in Afro-Americans that have this missense mutation of the PCSK9 gene, their Gaussian distribution of their LDL cholesterol is markedly shifted to the left to lower levels, and they also experience an 88% reduction in cardiovascular events. So this would be one shot in a lifetime if this would work with CRISPR-Cas9, and would probably cure us from atherosclerosis. And this is on the way. Here is the efficacy and safety of an investigational single course of CRISPR-based editing therapy targeting PCSK9 in non-human primate and mouse models. And you can see that the plasma levels of PCSK9 using CRISPR-Cas are reduced by 90% and LDL plasma levels by 70%. So this is very promising and is now tested in humans in New Zealand and Australia, and we will hear soon whether in the future we will be able to cure us from atherosclerosis. So the Verve Therapeutic announces clearance of investigational new drug application by the US FDA for Verve 101 in patients with heterozygous familial hypercholesterolemia, and they bring this CRISPR-Cas construct with Verve 101 attaching to the LDL receptor on hepatocytes to the liver to actually reduce the formation of PCSK9 for good. So gene editing with CRISPR-Cas9 is really from treatment to cure. And this is an example, CRISPR-Cas9 in vivo gene editing in TTR amyloidosis. And here there's another particle with a TTR gene and a CRISPR-Cas messenger RNA construct that is then packed into a libosome that through the ApoE opsonization will directly go to the liver to interfere with the formation of TTR. And here are the data. You can see gene editing in blue, in red the TTR messenger RNA expression, and in yellow the columns the TTR protein production that goes down down to 95%. So in elderly patients with TTR amyloidosis, this would allow it for cure with one shot in their remaining lifetime. So if you're interested in what I'm talked about, here is also a manual summarizing everything I've said, the manual in cardiovascular medicine that you can have in your pocket while rounding or doing a clinic to get up to date as we speak. And then, of course, if you rather would like to look at something, this is my YouTube channel, Inside Cardiology, where all these topics are also, again, accessible for you on what I just lectured today, but many other aspects of cardiovascular medicine. With this, I thank you for your attention. I would say we came from far, and we will get even further. I hope I could convince you of this exciting development of pharmacotherapy in the future. Thank you.